Well, good afternoon, everybody, or good morning, depending on where you are in the country. My name is Garrett Schmidt, and I am the managing editor and CEO for BBC Exhibit Hall. And I'd like to welcome you all to today's live webinar hosted by Health Data Analytics Institute. And today's session is called HCC Recapture Made Smarter, Not Harder. And data-driven insights of HCC opportunities with minimal impact to workflow. So there's a lot of great insights that's going to be shared. I got a little bit of a sneak preview of what's going to be discussed today, and I think you will really enjoy it. So a couple items of note before we get started. All of our attendees have joined today in listen-only mode, so you don't need to worry about taking off your camera or muting your mic or anything like that. Don't worry about that. That's been done for you. But we are going to have some time for some Q&A towards the end, and we'd love to hear from you. So you will have the ability at any point during the presentation to ask a question using your control module. There's a place for questions specifically on there. And if you drop your question there, we're going to get to as many as we can. We do have a big audience today. So if we can get to your question, we certainly will. If you don't, though, or if we don't worry, someone will reach out afterwards and make sure that we answer your question via email. Finally, the session today is being recorded. So what's going to happen is about an hour or so after we conclude, you will receive an email, and there will be a link to where you can watch the recording and also download the slides. And that way you can come back and watch it at your leisure and or share it with colleagues and friends, and we hope that you do that. So without further ado, I wanted to introduce our speakers today. We have Mr. Jay Simmons. He is the Executive Director and Vice President of Physician Services with TP-ACO. And we have Lauren Stuteville, and she is the Transition of Care Coordinator with TP-ACO. And then we have Julie Woods, and she is the Manager of Customer Success with HDAI. So welcome.
Thank you. Good to be here.
Thank you, Garrett. Yeah, so to get us started today, I'm just going to quickly walk through our agenda. So we just did our little welcome and introductions. Thanks again for everyone for coming. We're going to have Jay kick us off in a moment by going through what is an HCC, what is the concern with them, basically why do we care about all of this, and then Lauren's going to talk about how TP-ACO implemented the HDAI solution to create a workflow to make sure that they're getting that information to their providers. And then I'll walk through what is the HDAI solution, as well as some results from a preliminary case study we've done. So I think, Jay, over to you.
Okay. Hey, folks, thanks for joining us. So we have a lot of slides to go through. I won't take a whole lot of time, but we'll just hit on a couple of highlights. And if you have any questions at all, feel free to ask. We're more than happy to answer them. So bottom line, HCC coding is so crucial in the value-based care business. It helps us assess the overall risk of the patient, and it's not just about assigning codes. It directly influences the resources and care and plan for each individual patient. By capturing these key health conditions alongside of demographics like age and gender and stuff like that, we calculate a RAF score. And I imagine a good portion of you have researched that and heard about that. It's a risk adjustment factor score. And that basically predicts the cost of the care that the patient might need. Now, if we don't capture that to the highest level of specificity, struggle with that one, it can lead to an artificially low RAF score, which basically means the patient's true health status is underreported. And if that gets underreported, the predicted cost of care might be lower than what they actually need, and it can kind of snowball into other things. This is really critical for value-based care, where we all know that every single dollar counts. If our RAF scores are way too low, the gap between the CMS benchmark and the actual cost of care widens. And if that widens, it affects our ability to achieve shared savings. So getting the coding right is not just a technical necessity. It directly impacts both the patient outcome and the financial health of the ACO. Next slide, please. So here at TPAC, we knew we had to prioritize our efforts to make HCC Recapture effective. So we developed a strategy that really centered on helping our providers focus on their top 10 patients with the most recapture potential. Our goal was to guide practices and the providers to reassess the coding for these key patients and take some action. However, we did run into a challenge. We didn't really have a reliable or easy way to rank order these patients or quickly identify the highest HCC code. So the options we had, such as manually reviewing claims or searching through each individual provider or office EHR system, frankly, was inefficient and very time consuming. So that really wasn't something that we could invest a lot of time in. So we needed a solution that we could integrate smoothly into our daily workflows that providers and their teams who were, as we all know, already busy. So it was essential to find a way to do this that didn't overwhelm them, but help them focus on those top 10. This wasn't just about checking boxes. It wasn't just trying to get more information and push more information back. It was about simplifying the process and ensuring that every opportunity to improve patient coding was captured, and ultimately that the patients received the care they needed without the gaps. Next slide.
Okay, I think we have time for an audience poll here, so you can play along at home if you're with us. And I'm going to pull up a question here on your screen. And these are anonymous, by the way, and we're going to share the results with everyone so you can kind of see where you stack among your colleagues here. But the question is, how confident are you with HCC recapture initiatives at your organization? And again, this is anonymous, so it's okay to to answer honestly here.
We know it's a challenge. We certainly ran into it. It's not easy for most of us. It's not easy, especially in the ACO world. When you've got so many providers and so many clinics you're working with, it can be tough.
Yeah, and so you may have a little comfort to see when we share the results here that that you're not alone.
Yeah.
I think we've got most people have come in at this point. So we can give it another maybe 5 long seconds. 4, 3, 2, and 1. I'm going to go ahead and share the results here. All right. Are you guys able to see that on your end?
Mhm.
Okay.
So, it looks like about 18% of you, 24% of you have got it covered. That's awesome. That is great. 71% of you are still struggling with it, and I'm not surprised because we struggled with it too. Frankly, until HDAI stepped in and said, "Hey guys, we've got some options here." We were in just a little bit of panic mode. Not horrible, but we were worried, and we had spent quite a bit of time going out into our clinics with our providers, doing education, explaining what our RAF score was, explaining HCC, and disseminating all this information. But it's a lot. It's overwhelming, and our clinics are busy. So, with that being said, Julie, I'll throw it back over to you.
Yes. Well, hello
Lauren.
everyone. I'm going to talk a little bit about what our workflow was going into this big HCC project and how we went about deciding what we were going to do. So we really wanted to come in with a reasonable goal for these providers, a realistic approach. We know these clinics and these providers are already overwhelmed, so we didn't want to bring even more information to them to overwhelm them. So we decided to focus on their top 10 patients with the biggest HCC gaps. Instead of bringing every single HCC gap that we could find, we thought 10 is going to be reasonable for them. They can really focus in on these 10 patients and work on getting them into the clinics to close these HCC gaps. We also wanted to make sure we had clear ownership of responsibility, who was going to be pulling these HCC reports, because we wanted to get them to the providers in a clear way where we weren't having all this confusion on who's doing what. So we had to limit who was going in and pulling these reports and how we were going to get them out to the providers. So we gave 2 staff members the responsibility to go into the HDAI and pull these HCC reports on each practice, each provider, their top 10 gaps. And then we created folders for each practice so we could get them out to the care coordinators to mitigate any confusion on who was going to be pulling these reports. Next slide. So once we figured out who was pulling these reports and where they were going to, we needed to figure out how we were going to get these out to the providers and what was going to be the best way to do it to where it was going to make the biggest impact. So we have other care coordinators, specific care coordinators that have already relationships with these practices and providers. So we thought it would be best to have those care coordinators present it to their practices. We wanted it to be an open discussion with these providers. We wanted to actually sit down with them with these reports and go through patient by patient so they can communicate with us. Is this something you can do? Are these patients, do you have issues getting them into appointments? What is going to be the best process for you and how can we help you? So I found it best to go in person and do this. I just like to sit down with them. I would print the reports out with each patient, sit down with them in the office, go through patient by patient with them, show them where these gaps are, educate them on why these HCC codes are important and why you need to be doing them. And then they can kind of come back with me and say, okay, this patient has an appointment coming up. Let's try to get these gaps closed. So I wanted it to be more of a discussion versus we just sending an email out to them and telling them, you need to close these gaps, good luck. Because I think those emails get missed a lot, or they look at them and it just is overwhelming. They don't understand the importance of it. So really being there in person to guide them and explain exactly what they needed to be doing was very helpful for us. So we did get some good feedback from the providers. They really, I think, engaged with us. They preferred doing it in person versus, opening an email and saying, what is this? They liked to review those with us. And then they can go from there and say, okay, we have these patients. Let's get them in for an appointment. Let's get help from other staff members, get these patients in and try to close these HCC gaps. So I did have good feedback from them. Most of them were willing to do this. This was very accomplishable for them. They were happy with the 10 patients, and I think it went well. I think we had good feedback and a good response from all of them. I think Julie is next.
So I want to talk a little bit about how Health Vision made those determinations of, one, who those top 10 patients are, and within each patient, how do we understand which HCCs to focus on, considering there can be many HCCs per patient. So you can see here a little bit of a screenshot, but the big takeaway is that HDAI has access to the Medicare Research Database, or VRDC, and we're able to see HCC trends for all Medicare fee-for-service patients over time. So what we do is for each patient, we find all their HCC categories, and then we look at how often for patients who have this similar pattern are those recaptured year over year, as well as for where we are in the year, since there is a natural progression of, if you send any of these to a provider at the beginning of the year, they're going to say, well, I haven't seen any patients. Of course, they're low. So we try to take that into account as well. So we call that the weighted gap. So what you can see kind of in the little screenshot, and I have a screenshot a little bit later on that I'll call out in more detail. But what we do is we weigh the raw gap of the actual HCC against that expected recapture. So what we're really trying to say is, there might be a code that is a very heavy gap, so it's a very expensive code, but based off of how often it's recaptured, it's not typically something that we would expect you to go and get again. It might be an acute code, similar to that last one in the list. So we're trying to do a little bit of prioritization in terms of which codes to focus on when you're only trying to give somebody 10 patients and you're only trying to give them a few codes to focus on. And we do get this data weekly. We get it through something called the BCDA key for each of our ACOs. So it's going to be all fully adjudicated claims updated on a weekly basis, and it is regardless of whether that was diagnosed within your network or outside of your network. Next slide for me. So what we're able to do is, now that we've found it for all of your patients at the patient's level, is we roll it up. So to Lauren's point about her workflow, You can see we have a list of all the providers or provider groups, and we're able to see their capture performance based off of where we are in the year across both the patient average and the total patient panel. So we're able to kind of rank order those based off of what they would have expected to see for this part of the year and find the groups that maybe need the most assistance. And then once we've picked those groups, you can get that list of patients, and to Lauren's point, you can rank order that as well and get those top 10 patients based off of that captured versus expected. So you can see I've kind of highlighted that last one has a pretty high captured versus expected. There's a lot still left on the table for this point in the year. So they're marked as low. So if we were to kind of rank order this, this would be one of the patients that Lauren would have talked to the provider about. All right. So if you go to the next slide for me, once you've picked the patients from that list, so we have our top 10 patients, what Lauren was doing is printing out these pages. So you can see that weighted gap again is kind of rank ordered. So even though that final code there has the highest raw gap in the gap section, realistically, you're probably not gonna code a heart attack more than once, hopefully. So the weighted gap is actually a lower number, so it actually becomes one of the less important HCCs to go after. The additional insight we provide is the actual ICD-10 codes, which if you click into will open up a little pop-up that shows you how many times that code has been captured, who captured it, what the specialty was, and those little blue lines there show you whether or not it was this particular provider, so this patient's attributed provider who was the one actually capturing the code, or if they'd been captured outside of your network. And if you want to go to the next section. So we did do a preliminary case study. I do want to preface it and say we did it very quickly, so it was only over a course of a few months. So you can see here that even though it was a pretty short time frame, there were some pretty impressive results. So the overall gaps for all of TP-ACO decreased by 9% just from August to mid-September, which is a pretty high gap. So we're very pleased to see it. So everyone should tell Lauren that she did a great job. Jay, give her a raise. And you can see here we had 3 main provider groups that we focused on based off of the that rank ordering that I just mentioned. So for each provider group, we kind of captured in here how many patients they had. As the year progressed, the number of patients did increase, as is pretty normal because you get patients attributed to you. And then you can see the captured amount versus the gap amount. And between those kind of first 2 sections, we had all of those sessions that Lauren had. And you can see a pretty big change in the numbers. I'll go through them in a more visual way in just a moment. And then we kind of had after that, they kind of stabilized a little bit until we go back and talk to them again. So if you want to go to the next slide for me. So when we look at provider group A, who had about 130 patients, we saw there was an increase in the captured HCCs by 13% from July to September. So you can see here that purple shrinking. So going from a pretty high gap, going more than 50% to less than, which is really wonderful to see, even though they had an increase in their population by about 11%. So it was really promising to see that. If you go to the next one for provider group B. Provider group B is our smallest provider group. This one you really get a sense of if you only have 10 patients out of 36, you can really make a huge impact. So for this particular provider group, you can see they had the biggest jump from July to September in terms of how many gaps were closed. And then finally, if we go to our third provider group, which is our largest population, even though the population is larger, we still had an 11% increase in the captured HCCs. So overall, this was really promising to see, especially for groups that historically have struggled to get our HCC gaps closed. We don't expect to see this become a full green graph at the end of the year, so we will always expect some of those to stay in the purple because some of those might not be clinically necessary to capture again. But just seeing this amount of change in a short time was really promising. And I think if you go to the next slide, we have another poll coming.
All right, we do have another poll here. So you are going to see on your screen poll show up here. All right, and this one is based on this presentation. How likely are you to seek an HCC recapture tool for your organization? And again, this is anonymous, so it'll give you, we'll show the results here. It'll give you an idea where you stand kind of among your colleagues. And the choices are no need or no need. We have support in place already. Second is we would love to, but don't have resources for another vendor. Third is this is prompting me to look for a solution. And fourth is I don't think we need to focus on this right now. So we got some results here rolling in, so we'll give it another few seconds.
You know, while the results are coming in, I will say, you know, Lauren did a fantastic job working with the clinics, but the clinics are really glad to hear about this because the providers and the various seminars and documentation that they've been receiving, the magazines that they receive, all the resources the providers get, it's talking about HCCs. And while the vast majority of our providers were aware of it, there were some that really weren't aware of it. And so it opened the door for a lot of other conversations that I feel like we would not have had that opportunity had we started this initiative. So it's a great opportunity to make a difference. It really is.
Agreed. All right, I think most of the answers have come in, so I'm going to shut it down in 5, 4, 3, 2, and 1. There's always one that comes in right at the last second there. All right, let me go ahead and share the results. All right, are you guys able to see that on your end?
Mm-hmm.
Yes. Yeah, and I'm really impressed at how many people are already focused on this. I'm not surprised, but that 57% of you already have support in place is wonderful to see. I know there's been a big push across ACOs for this. And then when you I kind of look at the 26% and 17% added together of people who are struggling for a resource, I hope you can chat with Jay about potential ones.
Yeah, feel free to reach out to me. I'm sure they're going to give you my contact information. But yeah, more than happy to discuss this. Would be thrilled to discuss with folks because honestly, I learned so much during this process. It was amazing. I thought I knew a little bit. I didn't know much of anything. And working with these folks, it's made a really significant difference. So yeah, feel free to reach out.
And I do love that nobody thinks that this is not a focus area for them.
Yeah, I noticed that too. It is an important issue.
So with that, I think we've covered the bulk of our content, but we did want to make sure that there was room for questions.
Yeah, that's right. And so we do have a number of audience questions that have come in, and we've got some time to answer those. So if you have a question, by the way, for any of our speakers here, go ahead and drop that in now using your control module. There's a space specifically for questions, and we're going to get to as many as we can here. And in no particular order, first question is this: how is this solution different from my EMR or other vendors in this space?
Yeah, that's a really, really good question. And one I've definitely heard before from other clients, as well as this one, I think.
Sure.
There's kind of two main things. The first is that because our feed is updated weekly with all fully adjudicated claims, we can be sure that it is reflecting what CMS has. And it's EMR agnostic, so you're not just getting information from what your providers are coding, because your patients might be going elsewhere and getting these codes that roll up into HCCs diagnosed for them that you might not have visibility into. And the second thing is really that ability we have to track HCC patterns over time with the Medicare research database so that we can give you that weighted gap that really gives you a little bit of guidance before you even take it to the clinicians for where they should focus their efforts and gives them a little bit of a breather from the ones that make less clinical sense. So you're not just giving somebody a list of 25 codes and saying, hey, code these. We're trying to give you a little bit of that insight.
Yeah, great. Next question is this approach considering the change from V24 to V28?
Yes, yep, I will also nab that one. So the way HDAI does it is we actually have synthetic HCC categories. So we're taking into account the change from V24 to V28, and we'll kind of slowly change the categories as those move further and further into V28.
Okay, moving right along. Next question is, how can you be certain this improvement is from the efforts and not just organic gap improvement over time?
That's a good one. So this, like I mentioned, this was a short time that we saw these results. So we only had a few months of data. So it was a pretty dramatic change for that short amount of time, and we don't yet have the year-end RAF. So as Jay mentioned at the very beginning, the reason we care about these is because it impacts the overall RAF scores. So once we kind of have the end of the year, we'll be able to look at TP-ACO's RAF change from last year to this year. We do expect to see improvement there based off of these results. So we don't quite have that yet, but anecdotally, these provider groups historically really struggled. So seeing that big of a change over so short amount of time is really speaks well to that this was not just kind of natural, them catching the codes in regular visits.
Yeah, we chose these practices on purpose because we knew they probably had the most opportunity. So yeah, a couple more months and we'll know even more.
Very good. Next question. What's next in terms of spreading out to other primary care efforts?
Yeah, so we will continue to use this to get this out to the providers. I think we might do it more as like a quarterly project that we continue to do, but we are always out there visiting our providers and practices, making sure they have the education that they need. So we plan to continue to use this and still go by the top 10 rule. I think that's where we saw best success instead of overwhelming them with too much information. So our plan is to continue with the top 10, still bring this information to our providers because it is very vital for this.
Yeah, very good. Okay, next question here is, I like this one. Do you face any provider pushback? Or did you face any provider pushback?
You know, it's all in your approach, right? And we are lucky and blessed that our providers are amazing. We are all of our ACOs are provider owned, and we don't tell our providers how to practice medicine. We support our providers, we give them resources, we work with them, but we're very careful to recognize that this is a provider organization. So when we go in and we work with providers, they know we're not coming in to try to tell them how to practice medicine or what to do or how to do any of that. They know we're genuinely coming in with here's some data that you can digest. It's not massive, that we believe will help you. And it's, of course, up to you if you would like to participate or not. We don't push that on you. And we're very careful about that. I don't think we've really run into any pushback. Lauren, correct me if I'm wrong.
No, I had really good experiences when going into this. Now, if I were to just have sent out an email, we probably wouldn't have gotten the response that we did, but doing it like we did it and more so having a discussion about it, making sure that they understood the importance of this. And here's just 10 patients and your staff can help you get these patients in for this. It was 10 patients, they had good feedback from me. Okay, we think we can handle these 10 patients. We'll really dive into them. So I didn't have much pushback. Most of them were very open to this and were ready to accomplish it.
Yeah. Good question.
That was a good question. Next question here is, can you explain again what you mean by weighted gap?
Sure. Holly, if you don't mind going back for me a few slides, just to before the results, while she's doing that. Perfect. This one right here. So that weighted gap is a calculation of the gap itself. So each code has a weight to it, and this is the raw weight. This isn't including like the patient demographics, which is the other component that goes into your RAF score. So we have that raw weight in that gap column. And then that weighted gap is looking at that percentage, that kind of expected over time. So over the course of the year, the percent expected, so how much we're expecting this code to be captured for September 26th, what percent of the time, and then we compare that to the kind of overall gap score to get a weighted gap, which is a little bit overcomplicated to say it. So if I look at the last one in there, that acute myocardial infarction, it's a pretty expensive code. So if you look at it, it's that 0.43. So on its own, it has a pretty high weight, but it's not something that's typically captured year over year. So if we were to see kind of the raw numbers behind this, there'd be a percent of how often it's recaptured annually. And I would expect it to be pretty low, because when I multiplied it by that gap, the weighted gap gives me that 0.98. So what we're trying to say there is not just here's how expensive the code is, but how often is this code captured year over year, to give you a sense of, is this a code that makes sense to tell a provider to try to get the patient in to talk about? Does that make sense?
Yeah, no, I think that you explained that well. Okay, next question here is, how large was the total patient population, and how many total patients were included in the top 10 distributed to provider partners?
Oh, that's a good question. I think I might have to go and look at the data for
You have
exactly
to
how
go.
it is. I know that I can give it like estimates for sure, but Lauren, I don't know if you happen to know like roughly how many providers or patients you outreach to.
It was a lot. I'm trying to think. I mean, I know just personally for me,
Estimates are fine.
it was probably about 25 practices, and then 10 patients per, and practices have multiple providers, and then 10 patients break down for that. But we do have multiple other states with other practices involved also. So maybe 50 practices, and then broken down by provider and by patient. So that's why we wanted to have only 2 people pulling these reports, because you start getting too many care coordinators' hands in there. We wanted to make sure this was clear cut. All the reports looked the same. It was readily available. And then when we were ready, the specific care coordinator who works with that provider can then take that report to them. But it was a pretty big population of pulling those reports.
Yeah, well, kudos to you for pulling that out of your head, because I know it's a lot of numbers that you guys are working with. Next question here is, how are you defining biggest HCC gap? Is that a patient with the highest RAF, or patients with the most chronic conditions historically that did not have those recaptured?
I believe we did it, Lauren. Sorry, Ollie, if you go back to that same screen, we were just looking at it. We were doing it by that same weighted gap. So when we said biggest gap, we're doing it by the ones that have the biggest weighted gap. And when that's rolled up to the patient level, it's using that same exact weighted gap rolled up to the patient level, and then saying, okay, out of all those patients, who had the biggest weighted gap?
So who is still missing the biggest weighted gap for HCCs for 2024? And we were looking at who those top 10 patients were with the largest gap. And then we were breaking it down to this level that she's showing, where we could show them which codes are still missing for this year. And so they can have those patients come back in and reassess if those are still necessary to be recoded.
Gotcha. Okay, next question here is, when bringing these patients in to capture HCCs, are they brought in solely for that purpose, or are they brought in for annual wellness visit, exam, and HCCs are captured there?
It doesn't have to be specifically to recapture that. It just has to be reassessed in that visit. So if they already, some of us, when we would go out, they would say, oh, they've got an appointment already coming up, just maybe their 3-month follow-up appointment, and they can look at these diagnoses that are still missing for 2024, and they just need to reassess with the patient.
Yep.
make sure if it is still applicable, putting that in the progress note that they, reassessed for this so they can recode it for this year. So it doesn't need to specifically be for just to recapture this.
Great. Next question here is, I may be ahead of the curve here, but will you be able to quantify what is the financial impact of this effort?
We're hoping to.
Not right now.
Not right now. The RAF score, to again what Jay kind of mentioned at the beginning, does impact reimbursement for patients. So we're probably going to, instead of looking at this like straight dollars, look at RAF impact year over year once we get the full year picture. We're kind of hoping we'll have a full case study at some point early next year. But that's our kind of method right now. Jay, I don't know if you wanted to speak more about
Yeah,
that.
I'll just say that we are passionate about patient care. We don't, I know you guys are probably going to roll your eyes at this, but we don't worry about the financial end of it. We worry about the patient care end of it. We want the patient taken care of. The money always comes if the patient is properly taken care of, if everything's looked at. If you really look at all the issues that are going on, document it, whether it's an annual wellness visit, you're bringing them in for that or whatever, and just take care of everything, the money comes. So as an organization, that's not something that we focus on. But obviously that's a benefit to it, right? So yeah, that's just not our area of focus.
Great. All right, moving right along. Do you have access to clinical data or use that in your analytics?
That's a great question. This is actually all built just on claims data. So these are all fully adjudicated claims through the for MSSP patients. So for this project, we don't have like a feed to the EMR. So definitely something that HDAI can do separately is if we had an interface to an EMR, we can get like the pre-billing information that's being put in before the claim's fully adjudicated. But for this, all that was really needed is those fully adjudicated claims, which does also have the added benefit of being 100% certain that this is what CMS has. Because sometimes you might have things that are documented in your EMR, but if they never made it to a claim, then the CMS doesn't know it exists.
And we do have access to our providers' EMRs as part of our organization that, when we do audits and all sorts of other stuff, but then that kind of takes away the whole purpose of doing this. And it's one of them being time savings. If we try to go into every EHR and do this one by one, it would be a nightmare.
Yeah. Okay, great. Next question here is, do you have an opinion as to whether provider participation should or should not be incentivized by administration's encouragement?
Ooh.
That's all you, Jay.
Yeah, that opens a whole lot of other questions that if we were sitting across from each other drinking coffee, it'd be like, where are you going with this? What do you mean? I don't really have an answer for you on that one. I will tell you that we have not done that. But I've been told of other organizations that are looking at doing that, so I don't really have an answer. Sorry.
Okay.
Best I can give you.
No worries. I'm sure it depends on a lot of factors that are probably localized to that particular area.
Yeah.
Okay. Next question is, how is pricing for the tool organized? Per month fee or per provider or based on success and improvement, et cetera?
That's a good question, and I would say you should contact our sales department. No.
There you go.
Wait, Julie, aren't we getting it free? Wasn't that the?
Yeah.
Kidding, folks. We're not.
No, so it is typically our pricing structure right now is based by Benny counts. So we have a pricing structure that includes not just this, there's a variety of other tools as part of the Health Vision package. So it's typically based on a per Benny structure. I don't know the exact numbers. I am not in the sales department. But if you are interested in that at all, definitely feel free to reach out to either me directly, or I think Garrett is going to give everybody contacts, and I can kind of get you some initial thoughts.
Yeah, for sure. If you have an RFP, or wanted to reach out, obviously we're going to give you that information to do that. Real quickly, one last question here before we wrap is how do you predict if there is a high likelihood to recapture this year?
So we use historical data for that. So what we're doing is basically for each HCC category, we have those historical years that we can look at and then seeing how often they were recaptured so like 2023, how often was it recaptured for 2022, and then we apply that forward to 2024, and we'll do the same for 2025 when we switch over. So we are basically just using the historical trends for each of these codes. So there is a little bit of wiggle room as some trends change. There is also hopefully a focus in changing from unspecified codes to more specific
Specificity.
codes. Thank you. So there's a little bit of like room for growth in just kind of workflow generally there. But it's all based off the fact that we have that giant research database.
Gotcha. Well, very cool. Well, I think we got to all of our questions. We had a big audience, and thank you all so much for participating. Julie, Lauren, Jay, this was a fantastic presentation. Obviously, there's a lot here, and we are going to be sharing the slides and the recording. You'll receive an email after we're done here, maybe about an hour or so, with a link to the recording as well as to the slides where you can download those. I know I got a lot of questions to that regard, so don't worry, we'll get that to you. But as we're closing out here, I'd like to encourage you all to head over at your leisure to vbcexhibithall.com. And there you will find the HDAI virtual exhibit booth. And there's a lot of great information here about them. If you want to read up on what they're doing, kind of look into some of their resources, and of course you're able to contact them through that, and really educate yourself on them. And there's a lot of other great resources as well at vbcexhibithall.com. In our library, there's a huge repository of all kind of different material on a variety of different topics if you're ever wanting to brush up or do some research on value-based care topics in a variety of areas. So please head over there. And then finally, again, if you'd like to reach out to the team today or any of our speakers, feel free to do so. Their information is on this slide here, so you should see that. And but also, of course, you can feel free to reach out to me. I'm happy to facilitate an introduction for you if you would like, or if that would be easier. But thank you all again so much for spending your afternoon with us. Thank you, Julie. Lauren. Yes, Julie, what's up?
And super quick, just before everyone signs off, if any of you are going to be at NACOS in DC in about 3 weeks, I will also be there. So if you have any questions, you can ask me in person and come up to me. We'll have a little tabletop booth. And I will still have green hair, so I should be easy to spot.
Yes, green hair to match the green slide that we've got on there. So keep that in mind. And that is Julie. And I've met Julie, and she is a sweetheart in person. And so hope to see you all there as well. And thank you again, and hope you join us on the next one. Have a great day.
Thanks, folks.
Thank you, everybody.
Thank you.